and this IC is about the clinical cases of neuro-ophthalmology, which sometimes baffle us in making a clear diagnosis. And we will also be discussing the role of neuroradiology in making the diagnosis of these neuro-ophthalmological disorders. So I start with my case presentation. The first case was a 40-year-old female who was non-diabetic, non-hypertensive. She presented to us with the pain on the right side. It was a hemicranial pain, but was more focused over the periocular area, and it was there for 1 week. And 2 to 3 days following that headache, she had a double vision, and she didn't have any history of any systemic disorder, or she didn't have any symptoms of that suggests that she was a case of a migraine, and she didn't have any family history of migraine either. When we look at the past history of this patient, she had a recurrent attacks of pain with double vision that started from 2012 when she was 28 years old. And she had a recurrent attack sometime involving third or the sixth, and it was happening on either side. And like she had many attacks, and some of the attacks she showed to the ophthalmologist and sometimes to the neurologist. So we could have the medical records of these 4 case attacks only. But the rest of the attacks, as she knew they were always prescribing the same medicine. She took those medicine and got the relief, and some of them they were the self-limiting also, and some of the attacks spontaneously resolved over a period of 2 to 3 weeks. The investigation done at these past, when she had those recurrent attacks in past, the blood chemistry and the blood picture and the vasculitis profile as she was a young patient were normal, and even she had undergone CSF examination twice, and that was reported normal. The MRI done during those attacks, cranial and the orbital, and that was also reported normal. So she had the blood test, the lab test, and the neurological investigation, both of them were normal. So when we sum up the past history of this patient, she had a recurrent third or sixth happening on the right or the left side, around 6 or 7 attacks since a long period, for around 12 years. And the investigations and done at that time, not only the blood, the neuroradiology, and they all were normal. And she was always treated during these attacks by the steroids and analgesics. And these attacks resolved completely on the steroid treatment, and within a period of 2 months, and they were completely reversible without it leaving any neurological deficit. Mainly it was the 6 nerve involvement. And these are the imaging MRI of the cranial and the cavernous area done during those past attacks of 2012 and 15, and they were perfectly normal. There is no enhancement of the cavernous sinus lateral wall or the cavernous sinus lateral wall convexity. As we know, in some of these painful ophthalmoplegia cases, it can happen. So the recent attack, when she came to us, she had a right periocular pain, but was radiating towards the V1 distribution over the temple, frontal and the temple area. And 2 to 3 days following that, she developed double vision. So all the attacks which were painful ophthalmoplegia, they were very stereotype type of attack involving either the third or sixth, and there would be the headache preceded by headache, and that followed by any ocular nerve palsy, and that were short-lived, and they will be lasting only 2 months and responding very well with the steroid or analgesic treatment. So when she came to us, when we examined, she had a normal visual acuity. There was right esotropia, and there was a mild ptosis over the right side, which was not mentioned in the previous records. The pupil on the right side was smaller than the left, but the reaction was normal. The asymmetry was increasing in the dark. That suggests she had a sympathetic nervous system to the pupil supply is dysfunctional. And the fundus and the fields were normal. So we made a clinical diagnosis of painful right 6 nerve palsy with Horner syndrome, which together is called as a Parkinson's sign. And that localizes the lesion to the cavernous sinus. As we know in this diagram, that 6 is very close to the internal carotid artery and lies in the cavity of the cavernous sinus. And sympathetic postganglionic sympathetic fiber, they wrap around the cavernous part of the ICA. then leave it and run it, join the sixth nerve and run it for a short while into the sixth nerve. Then they leave the sixth nerve and go into the nasociliary nerve and enter into the orbit. So it's whenever we have this combination of clinical features like sixth nerve with the Horner syndrome, that specifically localizing to the region to the cavernous sinus. As we know, there is a long list of causes of painful ophthalmoplegia, but the commonest one I mentioned are Tolosah-Hunt syndrome, IgG4-related diseases, then sarcoidosis, vaginal granulomatosis, fungal infection, and neoplasia. Our patient's clinical examination symptoms and the clinical examination, or both of that suggested that patient have a ophthalmoplegic migraine, which is now named as recurrent painful ophthalmoplegic neuropathy. It used to be called as ophthalmoplegic migraine, but now it is called as a recurrent painful ophthalmoplegic neuropathy. So the clinical examination was very much suggestive of this last diagnosis. But the rest of the, like Tolosah-Hunt syndrome, we excluded because Tolosah has a recurrent attack, but not that frequent as our patient had. And secondly, the Tolosah-Hunt syndrome, sometime initially the imaging may be normal, but later on the imaging would always be showing the enhancement of the lateral wall of the cavernous sinus or the convexity of the lateral wall of the cavernous sinus. Sometimes there is soft tissue enhancement of the orbit, apex of the orbit. And IgG4 related, you know, in the patient usually have a paranasal sinuses enhancement on MRI, and the lacrimal gland enlargement, and infraorbital nerve thickening is also known, and they have a multi-system involvement. About that sarcoidosis, again, there is involvement of the your lacrimal and the parotid glands, and the seventh is more commonly involved in sarcoidosis. The vaginal granulomatosis, always there would be soft tissue imaging when you do the MRI, which patient never had in her previous attacks. It was a perfectly normal MRI. The fungal infection, again, there would be paranasal sinuses involvement. Is there thickening of the mucosa or the filling of the sinuses would be there. Sometime you may get normal sinuses with the enhancing soft tissue mass at the apex of the orbit, the cavernous sinus. Then only the biopsy can help, or sometimes the MRS studies, they can help you making other diagnosis. So the clinical examination, like history and examination, fits the diagnosis of recurrent painful ophthalmoplegic neuropathy in our case. So we did all the detailed investigation. As we know, it's a clinical diagnosis and a diagnosis of exclusion. So we have to investigate the patient thoroughly by lab and the neuroradiological investigation, and we found out that confirmed our diagnosis. And the main important out of all different causes which I told you about the painful ophthalmoplegia, the Tolosah-Hunt syndrome is the main differential diagnosis of this entity. And we know Tolosah syndrome is idiopathic granulomatous inflammation of the cavernous sinus or superior orbital fissure of the orbital apex. The MRI is always positive, and the changes what we get, always ask for enhanced, contrast enhanced MRI, because the plain MRI we may miss out this entity. And contrast will show the enhancement of the lateral wall with the convexity of the lateral wall, and the attacks are not that recurrent, and they are not short-lived, as if the patient had a duration of attacks were very short, but they are longer time, and sometime the recovery may not be complete, reversible. It might be leave some neurological deficit on recurrent attacks in Tolosah-Hunt syndrome, where our patient recover fully in all those multiple attacks. So we did the repeated investigation to make the diagnosis, and when we did our lab test and the neuro imaging was also normal. In even the cranial, we got the neck vessels MRA and do the lab investigation for sarcoidosis, X-ray chest, and MRI. We did the finer section of the cavernous sinus in the orbit, because sometimes some pathology to begin with, they are very subtle changes, and later on, when the disease progresses, the abnormalities they manifest more. So we repeated all, did the imaging of cavernous sinuses, orbit, the final cuts, and they all turned out to be normal. The MRA of this patient showed the right internal carotid artery was dilated in comparison to the left, and the carotid, it's a long segment of the ICA which was dilated, and even the posterior cerebral artery was very much close to third nerve on the right side. And even there was a posterior inferior cerebral artery loop near to the right sixth now in its prepontine when it runs into the prepontine cistern. So she had lot of vascular abnormality over the right side, and which can be the anatomical variation, and that were not responsible for the clinical presentation of our patient, because our patient was having these attacks third and sixth now on either side, not particularly over the right side. And any compression of this nerve, oculomotor nerve, because of these aberrant blood vessels, should be progressive. It would not be recurrent, episodic, as in our patient had, and it should not be recover over the attack. It should be a progressive one. So we also gave the patient a steroid, but the patient developed diabetes on that treatment. We switched over to her to Indocap, and she responded very well, as we have seen her previous attack that improved over a period of 2 to 3 months, but her pupillary asymmetry and the ptosis remained in this attack. So if we go through this entity, it's okay. So this patient is a recurrent painful ophthalmoplegia, but that is happening in adult patient, which was previously called as ophthalmoplegic migraine, and because International Headache Society renamed it as a recurrent painful ophthalmoplegic neuropathy. It's a rare disorder, more common in children less than age of 10 years, but in adults do get the cases. There are isolated case reports are there in the literature that this is entity happening in the adults. So diagnosis is a clinical, and it's diagnosis we have to investigate the patient fully to rule out other entity which I mentioned to you earlier. So pathophysiology is not clear of this condition, but it's supposed to be there are episodic inflammation of these ocular nerves, and which results into demyelination of this nerve, which later on remyelinate, and the nerve gets its function completely. So the diagnostic criteria laid down by International Headache Society are that the patient should have 2 attacks of the unilateral pain, and there should be the ipsilateral third, sixth, either isolated or in the combination, the palsy. There should be MRI should be normal. On MRI, there should not be any paracellular, orbital, paracellular, or posterior fossa mass. Third is most commonly involved, and next to involved is the sixth, and the fourth is rarely. MRI is most of the cases are normal, but sometimes it show the enhancement and or the focal thickening of the nerve. We got the Fiesta scanning in our patient also, but we didn't find any thickening or enhancement of a 6 now. So majority of these attacks complete reversible. Their complete recovery is there, and that happens in a short time, like the weeks or months. So I move on to my second case. That's about a 25-year-old male who presented to us as a dull pain in the right eye, and that was happening while the patient was taking meal or he was chewing, and that was there for last 2 months. He didn't have any other neurological signs and the neurological symptoms. So when we examined, the acuity was normal, the motility was normal, and the pupil was slightly sluggish. So we thought it might be something in the visual pathway like optic nerve or a chiasmal or something. It might be there because the pupil is slightly before the retrogeniculate pathway. It must be there. The pupil is slightly sluggish reacting. Fundus was perfectly normal. Because of the symptoms, that was suggestive that this patient is an atypical trigeminal neuralgia or a atypical facial pain. And why I called it atypical trigeminal neuralgia? Because we know trigeminal neuralgia is usually common in V2 and maxillary and mandibular divisions. Our patient is an ophthalmic division, and those attacks are lancinating and electric shock-like pain lasting for a few seconds. But this patient have a dull aching and was lasting as long as he was chewing the food. When we did the field, what we found was the supratemporal quadrantenopia. That suggested that there must be a compression in the chiasma, that too from the inferiorly, because we know in the chiasma, which is slanting structure, the inferior nasal fiber, they cross anteriorly, while the supranasal fiber, they cross posteriorly, and the central part is occupied by macular fibers. So there is a compression of the chiasma from below that suggests it must be a pituitary mass which was growing. supraciliary and compressing the chiasma from below. But surprising thing, the patient has a clinical presentation as if he had a posterior fossa mass, because posterior fossa mass can present as a atypical trigeminal neuralgia when it compresses the fifth nerve in its prepontine or cisternal part. So the field findings were totally different. Okay, I just sum up fast. So field finding was totally different from the clinical symptomatology of patient. When we did the MRI, we found a cellular mass which was extending supraciliary, paracellular area, and even the retrocellular area, and compressing the fifth nerve, impinging, as you can faintly see the prepontine the fifth nerve in the prepontine cistern on the other side. And on the right side, it was impinged by the mass. So that was a pituitary adenoma which was extending so much in the different surrounding area, but it was the retrocellular extension which was compressing the pontine part of the fifth, resulting in a demyelination of the fifth nerve, and which resulted into the non-synaptic transmission of impulses. That means while he was chewing the impulses which are carried by second and third division, they were also spreading out because there was no myelin, and was stimulating the ophthalmic fibers also. So he was getting the pain during that chewing time. So surprising that this tumor was extending so much in paracellular area, and only the clinical manifestation of the patient's symptom has only because of retrocellular extension. That can be explained because it is mentioned in literature that third, fourth, and sixth cranial nerves, they have lot of elasticity. They can be stretched 4 times of their length, but still they remain functionally intact. And secondly, the motor fibers, they have a large diameter fiber and they have a good myelin sheath. So their demyelination takes, or their compression, they resist compression for a longer time, while the fifth is a sensory nerve, which axons are the very small diameter one, and they are very thinly myelinated. So demyelination, even on compression by a tumor, happens early in the fifth nerve. So patient underwent craniotomy, and it turned out to be a chromophobe adenoma. That's why the patient didn't have any endocrinopathy symptoms, only the visual symptoms and this fifth nerve compression symptoms were there, and that made this diagnosis difficult in this patient. Okay, thanks.
Now I request Dr. Vikas Kanoja sir to deliver his talk, step-by-step approach to reach a diagnosis of neuro-ophthalmology. We will take up questions at the end of session.
Hello, yeah. So good afternoon to all. So my topic is step-by-step approach in neuro-ophthalmology. But in a short span of time, it is very difficult to that you combine all the cases of neuro-ophthalmology. I would try to just sum up with 1 or 2 groups of patients that can be can present with a myriad of symptoms and signs, and step-by-step approach with the clinical examination, fields, and imaging that can lead to diagnosis and the management of such cases. So what are the common clinical presentations for which that the patient presents to you in the neuro-ophthalmology OPD or in the ophthalmology OPD with the neuro-ophthalmological signs and symptoms, and they are also the indications of the imaging. First one is vision loss, for example, amaurosis phagox, optic neuropathy, junctional scotoma, bitemporal hemianopsia, or homonymous hemianopsia. These are the symptoms that the patient can present to an ophthalmologist primarily. So the other is anisocoria or ptosis. You can just proptosis. That can be because of the thyroid eye disease, orbital tumor, orbital pseudotumor, or any other CCF, and diplopia or ophthalmoplegia of any kind, oculomotor, or other supranuclear or internuclear ophthalmoplegia, gauge palsy, and orbital lesions, headache with decreased vision or with field effects, or some other your movement abnormalities, oscillopsia, and the last is the ophthalmoscopic abnormalities. Definitely these are the patient that is definitely coming to an ophthalmology with what? With optic disc edema or papilledema, you can say, and that can be because of some other reasons. So now coming with the first case, a male child, 12 years old, consulted their family physician in Kanpur because of the what? Because of headache. Age is 12 years, and this headaches they were becoming more frequent over the past years, and they were accompanied by nausea and photosensitivity, and that were relieved by sleep. So no pulsatile tinnitus, transient obscuration of vision, or diplopia. General examination normal. It was referred to an ophthalmologist, and he find out that the patient is having papilledema or bilateral disc edema. It was, now the patient was, because it was 12 years old, the ophthalmologist sent the patient to the neurologist for detailed workup, because he didn't put his efforts to what this, whether this is papilledema or disc edema, what sort of it is. So neurologist ordered definitely an MRI because of the papilledema that was mentioned on the papers. Later the lumbar puncture was done to rule out IIH. The patient was again consulted another ophthalmologist who referred the patient to our OPD. This was the picture, as you can very well see over here. The blood vessels at the margin, they are not obscured. There is no hemorrhages, no dilatation of the vessels or accompanying any hemorrhage nearby the disc. So what do you think? It is optic disc drusen, bilateral. So confirmed by the pre-injection autofluorescence and with your ultrasound B scan. But the patient has already undergone MRI. Okay. So it was a case of bilateral drusen. So you have to rule out what? Pseudopapilledema. And in a younger child, definitely, or in a mature adult, definitely do an A scan also to rule out hypermetropia also. So it was a pseudo disc swelling, and it can be because of the small disc, tilted disc, elevated disc is superficial, but unappreciated drusens. Now you have OCT also to appreciate the drusens. So case number 2. Again, this is a case of papilledema, not disc edema this time. 28-year female comes to the OPD with a history of recurrent attacks of headache for past 3 months with sudden development of intense headache. This is intense headache. Now this history is very important. So step-by-step approach means that everything is very important. So intense headache for past 3 to 4 days. She is a 28-year obese female and she was having restricted movement right side. That means abduction is deficient and diplopia for 5 to 6 days during the episode of that intense headache, and decrease of vision in the left eye for past 1 week. No history of seizure episode or any other neurological deficit. So vision was 624 in the left eye, and as you can see, there is an abduction deficit. Okay, abduction deficit in the right eye. Very well, you can see over here, not going to the your angle of the little canthus. So this was the picture. So definitely this is not an disc edema. This is, you can say disc edema unless until you get the MRI done with there is increased intracranial pressure. So this is papilledema, what I am saying right now, because of the hemorrhages are there, no obscuration of margin, that your vessels at the margin with exudation. So this is definitely a papilledema with this constriction of field of the one side and restriction that your field effects on the other eye, generalized depression on the other side. So MRI, MRV with contrast was ordered. This contrast is very important. MRV with contrast, because in MRV, plain MRV, you don't inject any contrast. MRV contrast is injected to rule out something else. That means the external compression or the internal compression of the transverse sinus. That is the role of the contrast. And this is the pictorial representation of, this is your suprasagital sinus, transverse sinus, and this is your sigmoid sinus, and this is IJV, where that your whole of the sinus blood from the brain is drained into. And this is what the MRV of the patient, you can see, this is the left transverse sinus, sigmoid sinus, and this is IJV. This is hypoplastic, but it's because this is constricted. And over here on the right side, you cannot see over here the sigmoid sinus. So it can be come down over here. This is the constriction, the stenosis or the constriction, or you can say the narrowing of the transverse sinus. So what came out to be? This came out to be a investigated for coagulopathy, 28 years old female, and she came out to be anticardiolipin syndrome. So considering that your cerebral venous sinus thrombosis, because intense headache for 5 to 6 days. That is what the important in the history was. And she was started on anticoagulant and the oral acetazolamide. She improved with all her symptomatology and with your papilledema and everything, and she was now on follow-up for last 18 months. So again, the third case, again the same patient, 50-year-old female presented with complaints of headache. Now this time around tinnitus is there, decreased vision both eyes for last 8 to 9 months, 6-12 both eye vision, fundus shows chronic papilledema, because the symptomatology was there for 6 to 9 months. Field, enlarged blind spot, generalized constriction of field. This you can see chronic papilledema, constriction of field. This is your OCT, RNFL showing increase your thickness. And now this is a T2 weighted, you can see this is an axial section. Over here you find fluid. This is the sella area, fluid in the sella, that means empty sella is there. Pituitary is shrunken, that is the reason whole of that sella is filled with, that is what we call as empty sella. You are seeing the fluid over here. And this is your dilated optic nerve sheath. So MRV definitely was ordered, and over here you can find out. This is the transverse sinus, sigmoid sinus, IJV. Over here this is absolute hypoplasia, and there is definite stenosis of the transverse sinus, junction of transverse sinus and sigmoid sinus. So what was ordered? Next is you have to order DSA, digital subsection angiography. And on digital subsection angiography, this is your IJV, this is your sigmoid sinus, this is your transverse sinus. I'm just predicting it from below. And over here you can see definite stenosis of the junction of the transverse and stenosis, that your sigmoid sinus. And this is your what? This is when you have filled the dye, and this is coming over here. So this is exactly the transverse sinus, and it is going into that your superior sagittal sinus. Now what happened? This is what was done. The patient underwent balloon angioplasty with stent placement. This is the balloon. Over here you can see very well, this is the balloon to dilate the stenosed part, and this is the mesh. Mesh you can see, I think. This is the meshed area. This is the stent, as just you put in your cardiac stent are put. So this is post stenting. You can see now DSA, everything has opened up. This is pre, this is constriction. Very few dye is going over here. So this whole of the dye is now going the other side. So you have relieved of the patient of the symptomatology and all of that what is coming out of this stenosis. So papilledema resolved. This is now on the right side you can see the nerve fiber layer has come down. So now the coming to the case 4. This is now different myriad with the oculomotor deficits. Okay, a middle-aged patient with a history of gradual decrease in vision in both eyes and ability to move his left eye towards left side. That means abduction. So, but importantly, this patient was on hypertension, but controlled on one drug only. Important is controlled on one drug. I've checked all that whatever that the chart he was having, it was controlled. So 612 and 618 was the vision. This is now you can very well see left, third, 6 now paresis. You can see abduction deficit over here. So what would you think? Hypertensive, 6 now paresis, many a times, because this is what the teaching is, don't get a MRI done, hypertensive, it would wait for 1 or 2 or 3 months, it would resolve. But no, this should not be done. Many a times, middle-aged, 40s, 50s, so hypertensive, but even though you have to order a field, and now you can see very well, the field is there. Bitemporal defect, okay, and there is constriction of the field on the other side also. And now this is the MRI. Axial section, very well you can see, T1 weighted axial section, you can see with contrast, okay. So this is what? This is a sella and suprasellar tumor. This is sella and going beyond sella superiorly, so suprasellar tumor having a lateral extension into the cavernous sinus. As the Kumudni ma'am has shown, lateral extension, because internal carotid artery is contiguous with your 6 now. So it is extending into the cavernous sinus, and now what is this? This is the 6 now. This is the your ICA, and this is 3rd, 4th and other nerves. So this is extending. This is the pituitary. This tumor was going over here and over here also. So 6 now. Initially the 6 now was affected. So paracellular lesion, I'm not going into detail, all these sella and paracellular lesion which can go beyond the boundary of the sella, go upward, supracellular, go lateral extension of the tumor. So ocular motility affected when pituitary tumor or any cellular tumor or supracellular tumor extend into cavernous sinus. 3rd nerve is the most commonly affected. Then comes your 6th nerve. The difference was with our patient that the 6th nerve was first affected. So again, this is what many a times you get. Hypertensive diabetic patient having 3rd nerve involvement. Ptosis, you can very well see over here, your abducted eye, 3rd nerve affected, pupil affected. So what would you do? Now there you have to go for MRI, imaging, and imaging with contrast. Definitely always, you just have to write imaging with contrast also. Fine. So this is an axial. This is a coronal section. Very well you can see over here, this is the cavernous sinus area. This is again the cavernous sinus area. This is the normal ICA on the other side. Okay, you can see the flow wide over here. And this is what? This is a partially thrombosed ICA aneurysm intracavernous. So partially thrombosed intracavernous aneurysm. So that is the reason the symptomatology was there. And this is the MRA. MRA, you can see this is the other side, and over here, this is your ICA, but over here, this is because partially thrombosed, so little bit flow is going through that part of the ICA, internal cavernous ICA. Over here, this is the same. This is normal. Okay, this is the ICA. On the other side, you can see very well the part going through the cavernous sinus. So case number 6, a middle-aged male presented with difficulty in depth of perception. Now, difficulty in depth of perception of moving objects and inability to move eyes sideways. Now, right eye was having restricted abduction and adduction, while left eye limited abduction and restricted adduction. So mixed bag of things. You cannot conclude whether this is an INO left INO, right INO, Wabino, or 1.5 syndrome. But importantly, MRI shows two lesions. One in your, this you can see abduction. This is the eye in the primary gaze. What we have clicked the photograph, and this you can see. Now just the patient is asked to follow the finger, and you can see patient's own finger, right eye abduction deficit, even the left eye is not adducting. Fine. So now you can see very well the lesion, where the lesion lies. This is the pons, this is the lower pons, this is the medulla, and this is the fourth ventricle. The lesion is lying over here. The patient was having papilledema also, because it was causing obstructive hydrocephalus, and the symptomatology was increasing. So definitely something needs to be done. Importantly, one more lesion was found over here in the parietal cortex. This is at your frontal cortex. This is another lesion, and both were similar in their morphology. So definitely, because the fourth ventricle and the exit to that your medulla, it was obstructed, CSF was obstructed. So definitely neurosurgeon intervention was needed, and they have debulked the pons. And after debulking, the pontine lesion that was debulked, and biopsy was done, and came out to be a caseating granuloma. So definitely two lesions were there, one in cortex, one in over there, obstruction was there. So ATT was started, and the lesion resolved. This is after the debulking and starting you can see very well now the patency of, this is fourth ventricle, this is third ventricle coming over here, and patency is maintained. Now one more thing, that frontal lesion, that it resolved, but unfortunately on successive MRI, because they were done, the patient was having already a pituitary adenoma also, and it was again operated. So this is how you have to just think of getting the clinical examination, fields, and MRI. And MRI has to be ordered very meticulously. You have to write everything to the radiologist, because he would not be able to know कि मुझे करना क्या है उसके अंदर. So as an ophthalmologist, you have to know the paranasal sinus, brain anatomy, basics of CT and MRI, interpreting the scan, because what we do, film आती है, पहले हम just take the report and okay, अगर कुछ ऐसा लग रहा है, there is something, just refer the patient to neurosurgeon or neuroradiologist, or your neuroradiologist or neurologist. But you have to know about कि film पकड़ी है, I am holding the film, whether this is a CT, कौन सा sequence है, कौन सा area है. So that is the reason you have to, basic ophthalmologist always tell you regarding the anatomy of the cellar, paracellar, and other things. I'm not going into detail because now the time is up, because there are a little bit, some slides were there with the how would you identify the CT scan, how would you identify the MRI, which is to be ordered. I think this is beyond the scope because the time is up. Now, take home message is, ophthalmologist may be the first contact physician with varied ophthalmological and other systemic features of a disease. So thorough ocular and systemic history, thorough ocular examination, and definitely systemic examination referral to other specialties like neurology. So ophthalmologist should provide the interpreting radiologist or interventional radiologist or the radiologist who is going to do the scan, the pertinent information regarding the patient's clinical profile, including the differential diagnosis you are having in your mind, the suspected location of the lesion to obtain the best neuroradiologic interpretation, and the information regarding the nature of the suspected pathology is important in deciding the protocol of the examination, and intravenous contrast is needed or not. Thank you.
Now the next speaker is Dr. Arun Kumar Singh, and he would be talking about the visual field interpretation in glaucomatous and visual pathway lesions.
Thank you, ma'am. Good afternoon, everyone. I will be talking about visual field interpretation, glaucomatous versus visual pathway lesions. First, I will be covering some basics. Retina can be divided into temporal half and the nasal half by an imaginary vertical line passing to the center of the macula. The nasal retina correspond to the temporal field, and the temporal retina correspond to the nasal field. So the nerve fiber layer, these are the axons of the ganglionic cell layers, which are arranged in a typical manner. The macular fibers are known as papillomacular bundle and are inserted into the temporal part of the disc. The temporal fibers arch around the papillomacular bundle and are arranged in the superior and inferior part of the disc, and the nasal fibers go directly into the nasal part of the disc. They are arranged in such a manner that the peripheral fibers are in the periphery of the optic nerve and the central fibers are in the middle of the optic nerve. First one is the arrangement of fibers in the optic nerve head, in which the macular fibers are in the temporal region. And the second photo, you can see that the arrangement of fibers in the retrolaminar region. So that macular fibers which are temporal come in the middle of the optic nerve, preserving in the later on stages of the diseases. Now the visual pathway. The optic nerve carries the temporal and the nasal fibers. The nasal fibers decussate at the chiasma and go on the opposite side, forming the optic tract. The optic tract contains the temporal fibers of the same side and the nasal fibers of the opposite side, and relay into the lateral geniculate body. Now from the lateral geniculate body, there is the optic radiations which relay the information to the primary visual cortex. Now mainly the anterior visual pathway lesions, especially optic nerve lesions, mimic glaucomatous field defects. Due to the anatomy of the visual pathway, a visual field defect which occurs due to a pathology at either chiasma or more posteriorly often affects the nasal or the temporal visual field. Now the field defects. First, it can be central or psychocentral scotoma. It can be seen in nutritional, toxic, or hereditary optic neuropathy. First is the central, and second is the psychocentral scotoma. Next, it can be arcuate and altitudinal field defect, seen in the non-arthritic type of AION. First is the arcuate scotoma, and in the second picture you can see altitudinal field defect. It is due to the involvement of the short posterior ciliary arteries, either in the superior half or the inferior half. Next is the junctional scotoma. It is seen when there is a lesion at the junction of the optic nerve and the optic chiasma. It is produced as we discussed earlier. The nasal fibers cross to the opposite side, but before crossing, they form an anterior Willebrand knee in the opposite side of the optic nerve. So if the lesion is there, the optic nerve of the same side will be affected fully, and in the opposite side, because the inferior nasal fibers are involved, so the superior temporal field defect will be seen, as you can see in this field. Generalized constriction of visual field can be seen in perioptic neuritis. And the bitemporal and the binasal hemianopia are seen in the chiasmal lesions. Mainly bitemporal hemianopia is more common, binasal is rare. Bitemporal hemianopia can be seen in the pituitary adenoma and carinopharyngioma, causing the field defects. Next, the homonymous hemianopia. It can be complete or incomplete. In the upper picture, you can see there is a complete homonymous hemianopia. In the lower fields, it is incomplete. It can be either congruous or incongruous. In the first lower field, you can see that the optic field defects are almost similar. So this is congruous field defect. And in the second picture, you can see that the field defects are not almost similar. So that is incongruous. As we move posteriorly to the visual pathway, the field defects become more congruous in nature. These field defects can be seen in optic tract lesion and the lateral geniculate body lesion. Next is homonymous quadrantonopia. It is seen in the lesions of the optic radiations. The inferior fibers form the Mayer's loop and go to the temporal lobe, and the superior fibers go to the parietal lobe. So if there is any lesion in the inferior fibers, superior field defect will be seen, known as pie in the sky. And if the superior fibers are involved, then lower field defect will be seen, known as the pie on the floor. And the occipital lobe lesions are more congruous in nature, and it may be macular sparing. Now, a few points about the visual field defect in glaucoma. Glaucoma is a neurodegenerative disease of the optic nerve. It is progressive, irreversible loss of retinal nerve ganglionic cells, resulting in irreversible visual impairment and eventual blindness. It affects the RNFL layer, which is anatomically distributed superiorly and inferiorly. Glaucomatous visual field defects tend to affect the superior visual field or the inferior visual field, depending on which fibers are involved. And the visual field often does not cross the horizontal midline, referred to as respecting the horizontal midline. So what are the field defects can be seen? First is the paracentral scotoma, nasal step, arcuate scotoma, and generalized constriction of visual field. Now how to differentiate these lesions? In glaucoma, the onset will be slowly progressive, and in the visual pathway lesion, onset will be acute or subacute. Disc in the glaucoma will see cupping with thinning of a neuroretinal rim, but characteristic will be that the color of the neuroretinal, whatever will be left, will be pink in nature. But in the visual pathway lesions, cupping may or may not be there. It can be seen in AION and pituitary adenoma, but it will not match the visual field defects, and an NRR will be pale. IOP will be generally raised in glaucoma or in visual pathway lesions, IOP will be normal. Visual acuity will be affected late in the course of disease, and in visual pathway lesion, visual acuity will be affected early in the course of disease, except in chiasmal and post-chiasmal lesions. In glaucoma, no or mild APD will be seen, and in visual pathway lesion, significant APD will be seen in these cases. And in glaucoma, no neurological sign will be there, and in the visual pathway lesion, associated neurological signs and symptoms will be there. And visual field defect respect the horizontal meridian in the glaucomatous field, and the visual pathway lesion, it will follow the vertical meridian. OCT also shows RNFL and GCIPL loss corresponding to horizontal meridian in glaucoma and vertical meridian in visual pathway lesions. Now few cases. A 48-year-old male presented with heaviness in both eyes for 6 months. On examination, his visual acuity was 6/9 in right eye and 6/12 in left eye. IOP was 24 and 21 mm of mercury. On gonioscopy, angles were open. Fundus showed cupping of 0.9 in right eye and 0.8 in left eye, with inferior thinning of NRR. This was the OCT RNFL. It showed the inferior thinning in both the eyes, and corresponding superior field defect was seen in the field examination. So it was a case of open angle glaucoma. Case 2, a 38-year-old female presented with the complaints of painless progressive decreased vision in left eye for last 2 to 3 weeks with headache. She had similar recurrent attacks for last 6 months, for which she was given steroids 2 or 3 times, and it resolved. But the field examination and imaging was not done. We did field examination and it showed temporal heminopia in right eye and temporal heminopia with central scotoma in the left eye, as you can see in this field. On imaging, a large cellular mass with cerebral liquefaction extending to the supracellular region with a peripheral enhancement, and it is displacing the optic chiasma superiorly, causing the field defects. Case 3, a 56-year-old diabetic man presented with history of dull pain in the left eye with drooping of left eyelid for 2 to 4 weeks. On examination, complete third nerve palsy was found with mild weakness in his right lower leg. Field examination was done, and it showed to be a right homonymous hominopia with mild weakness in right lower leg. On MRI, there was a mass in the anterior medial temporal lobe extending to the adjacent cavernous sinus, also extending posteriorly and compressing the left cerebral peduncle, causing the mild weakness in his left leg. Thank you.
So the next speaker is Dr. Priya, and she would be discussing some of these problems where we find it difficult whether it's a cause of visual loss is maculopathy or it's a neuro-ophthalmological disorder.
Good afternoon, all of you. Thank you, AIOS, for giving me this opportunity, and thank you, Kumudini Madam, for including me in this instruction course. So my topic of discussion is retinal diseases masquerading neuro-ophthalmological problem. So usually when we have some symptoms like phospins or photopsia, visual acuity loss is not that much, or visual acuity loss is little bit debatable. Visual field defect, usually centrocecal scotoma or blind spot enlargement, and fundus findings are very less. There is paucity of fundus finding. So in these cases, usually we think of that is a neurological problem, and we store. So we will see each history and clinical examination is important in differentiating that is a retinal disease or it is a neuro-ophthalmological problem. Initially, one by one we will go to symptoms first. If patient is giving metamorphopsia, metamorphopsia usually a sign of macular disease, that is distortion of object, and usually it can be associated with central scotoma and micropsia. Next is phospin. Phospin means seeing lightning type, but how can we differentiate based on phospin only? If it is a retinal phospin, that is more visible in dark. And why it is? Because of traction of retina, traction of vitreous on retina, and some retinal inflammatory conditions also can produce phospin. But some literature also shows that optic neuritis can also show phospin is reported, and it is more commonly associated in migraine. But how can we differentiate that it is retinal phosphine or migraine? Migraine, whenever a phosphine is associated migraine, it is usually a hemianopic pattern, one-sided, and that the typical fortification spectra or tecopsia, different terms are used, that is one-sided scintillating scotoma, and it is not affected by light, whether you are seeing in dark or whether seeing light. So that usually we can know that it is migraine. Or in retinal phosphines, they are better appreciated in dark. Pain on movement, as we know, it is a typical features of acute optic neuritis. So whenever there is no pain, either it is an other ischemic compressive neuropathy or it may be a retinal disease, but not typical optic neuritis. Loss of color perception, as we know, can be decreased in macular as well as optic neuropathy, but in optic neuropathy it will be out of proportion, whereas in macular diseases it will be comparable, degree of vision and degree of color vision. RAPD is there, mostly neuroophthalmical, although I can show some retinal disease can produce subtle RAPD, but it is mostly, we take that it is neuro-ophthalmological problem. Clinically, then we can do a visual field test. Visual field testing if show enlarged blind spot. This sign is very important. When we see, we know that optic disc edema can produce blind spot enlargement, but for blind spot to be enlarged, the edema should be that much severe to produce constriction of field. If we are seeing fundus examination, either there is no optic disc edema or disc edema is very subtle, mild blurring of disc margin, but we are seeing blind spot enlargement, then obviously it is not due to edema. It is some retinal disease usually affecting the peripapillary retina. And we can do clinically photostress test, very important, simple test, bright torchlight can be seen in undilated eye, and you ask the patient to read before the shining light, and when you remove the source of light and ask the patient the time interval between removal of the source, and patient can read one line above the BCVA, that is the time interval. In macular cone functions, the recovery is very slow, in minutes, whereas in optic neuropathy it can be around 30 seconds. So from that also we can give a clue that it can be retina. So I have categorized, there are so many diseases, so I have categorized some disease accordingly. One group is, as we can see left side, acute idiopathic maculopathy, acute retinal pigment epithelitis, azure complex, and acute idiopathic blind spot enlargement. I am not going to detail each disease, but some very overlapping common features, that these are acute onset scotoma will be there, female preponderance, usually myopic female, and there will be enlarged, either patient will say central or centrocecal scotoma, and so there can be gas has stated that this should be comprised as azure complex. We can tell, so azure complex is designed for that female preponderance, unexplained vision loss, and enlarged blind spot. Photopsia will be there, ERG. So one by one, just touching this condition, what are those? Acute idiopathic, viral prodrome will be there, acute onset unilateral painless vision, and disruption if we do. So we should take the help of multimodal imaging always when you are facing this type of complaint, before jumping that it is a neuro-ophthalmological problem and order MRI and all. So you should do take the help of whatever investigations we have with us. So here we can see there is a disruption of the ellipsoid layer, hyperreflective debris, and exudative macula, and it resolve uneventfully in most of cases in 4 to 6 weeks. Acute pigment epithelitis also little bit of same, female preponderance, a flu-like history will be there before, and so these are have overlapping pictures also, and spontaneous recovery is there. Then coming to the azure complex, the original azure acute zonal outer retinopathy, you can see that some zonular retinal effect, and these are all outer retinal disease. Till whatever I have told till now, these are outer retinal disease affecting, as we can see in the OCT, this is disruption of the outer photoreceptor layer, ellipsoid zone, interdigital zone. We can appreciate, and in autofluorescence, a typical trizonal pattern, that means outside area is normal autofluorescence as we can see right upper picture, and a speculated hyper-autofluorescence in the active area, and inside is the atrophic area, that is hypo-autofluorescence. So if we do multimodal imaging, we can pick out these diseases even if the fundus picture is very subtle. Obviously, gradually when we follow these cases, they can present with a characteristic pictures like that is grayish-white zone, but initially we may miss this condition. And it has a variant which is called acute annular, that means it is a peripapillary conditions. So we have also one case, this is Kumudini madam. Thank you for madam sharing this patient's data and telling her experience. This patient also was referred from a retina specialist for neuro-ophthalmological workup, and all tests should be done including Leber's hereditary optic neuropathy also. Gene test was negative. So gradually this patient, as we can see, acute onset scotoma was there, and after a follow-up of a period of time, gradually those grey-white zones came to appear and patient was finally diagnosed azure. So it was a follow-up, and so her experience was that this type of things can be. Also our literature also show this, we can see this multifocal ERG. As we can see, this is macular, that peak, macular peak is not there in right side photo. So that is severe macular atrophy. So ERG also plays important role in this. So literature also says that these type of cases are frequently misdiagnosed. Like 15 years, they are diagnosed one disease and finally found out to be azure or something else like. Then acute idiopathic blind spot enlargement. How we can tell? There will be a grayish, just let comes to the picture. There's a beautiful picture by Zimmerman et al. We can see that is the grayish halo. You can see the optic disc like a grayish halo it is seen. Actually that is the retinal diseases that affecting optic nerve, and you can see with this type of, the edema is not much prominent, but you can see how the blind spot is enlarged. And with sequential, without steroid use is also controversial, you can use steroid or not, but it improves. And so this is acute idiopathic blind spot enlargement. Then coming to the next group, one is acute macular neuroretinopathy and paracentral acute middle maculopathy. Lots of association has been, usually most CRVO, BRVO, ischemic events and viral prodromes, shock, intravenous drug history like epidrapine, trauma, preeclampsia, all these has been associated. There are lots of in literature cases. So we should know these entities also because they have very subtle fundus picture. If you know these and do the accordingly test like this, acute AMN, it will like a deep dark red lesion, very subtle pointing to retina. It is the disease of outer retina, mostly deeper, involving deeper retinal capillary plexus, whereas paracentral is the middle, affecting the middle capillary plexus. We have one case, as we can see, this is the 50-year-old male with acute onset scotoma. Vision was not affected 6/6 and anterior segment findings were unremarkable. So we can see only the tortuous of blood vessels. So we suspected this is grade 2 hypertensive and impending CRVO, and on field also we can find some focal loss area. And in see the OCT, we can see in the middle layer of OCT right eye, above one first picture is right eye, we have hyperintensity, band like hyperintensities, whereas the comparative compared with the left eye OCT is absolutely normal. So, and it is very dramatic experience. N-phase OCT, macular scan, there is N-phase facility. So if you see N-phase, see the perivenular fawn-like appearance, globular appearance or fawn-like appearance, whereas the B is the normal eye. So we can compare. Very dramatic picture, whereas fundus was absolutely, you cannot see these lesions. And also in fundus autofluorescence and angiography you can do to add this. Last, only I am telling the name because detail will be beyond the scope of this discussion. One is paraneoplastic autoimmune retinopathy, can be carcinoma associated, melanoma associated. So they also affect the outer retina, photoreceptors and outer retina. All these symptoms will be there like night blindness or photophobia, sensitive to light. So any elderly patient, no history, you may not get a malignancy history, but elderly patient acquired nyctalopia along with and fundus finding, very subtle fundus finding. You may not early stage fundus will be absolutely normal. So think of some underlying malignancy and do workup accordingly to find that malignancy. So this is the paraneoplastic autoimmune retinopathy. And toxic retinopathy, as we all know, there are lots of drugs, vigabatine, chloroquine, and definite screening protocol is there for all drugs. So we should take the drug history also. It may be a side effect of the drugs. And finally, retinal dystrophy. As we know, these are obvious manifestation in later stage, but in very early stage, especially when sign pigmento, sectoral retinitis pigmentosine, where pigments are not that very clear, or any other dystrophy in early stage, they can also mimic this type of neuro-ophthalmology. So we should, if we know this entity, if our mind knows, then we can do the workup. We have some equipments in our hand, so we can do this test and clarify what the disease is before just jumping to or sending to neurologist or ordering an MRI or all this. Thank you for your kind listenings. Always take the help of this. Thank you.
Now our last speaker is Dr. Suchita Parijat, and
Azure usually has been reported to progressive.
Okay.
Sometimes bilateral also, because what has already literature shows that 50% cases ultimately developing bilateral. We are only concerned when it is the early stage, when there is, because in bilateral obviously the typical degenerative changes of retina starts with all the bony spicules like changes, also arterial attenuation within that scotoma area. But in initial stages, you can clearly associate that scotoma area and age of the lesion.
Okay.
So definitely you should follow up those cases.
Okay, but there is no treatment as such that we would be
Azure as
giving.
such has no treatment, steroid use, immunosuppression, and other, in all disease, whatever conditions I told. First category was those are self-limiting most of the cases except Azure, that is acute idiopathic pigment epithelitis. Those heal, either you use steroid or not. But
Okay.
later cases you should at least.
Okay, and are these associated more with myopic eyes, as you were saying?
Female preponderance and myopic eye. Whatever this disease has been reported in literature, you can see that these are female patients mostly and myopic eyes. So as you.
Thank you.
Very good afternoon. I'll be speaking on Anil. Very good afternoon to all of you, and I thank Dr. Kumudini madam to give me this stage to talk to you. So I'll be talking on isolated cranial nerve palsy. What's next? Is it a benign or a malignant thing, and should we be concerned about it? Because what others do we only take up as ophthalmologists these cases, or we should have a collaboration with other physicians and neurologists? How do they present to us? I have no financial interest in this presentation. An isolated cranial nerve palsy presents a multifaceted challenge in both diagnosis and treatment. As we know, the etiology of an isolated third nerve palsy, just I'll be focusing on one, is diverse and can range from benign to life-threatening. And the key considerations, which is very important, we look at the pupillary involvement. We always ask for a history of microvascular or a trauma. And there are always mimickers, and we should keep it in mind, be internuclear ophthalmoplegia, myasthenia, or a thyroid eye disease also. And to avoid misdiagnosis, a thorough understanding of its anatomy and symptoms and etiology of the cranial nerve is quite essential. So we give you certain case-based, and let's understand what it is. A 60-year-old female who presented with double vision since 2 days. So it was quite sudden, but when we asked her, she was not very clear actually what it was, and after it was followed within 2 to 3 days, followed by drooping of the right eyelids. With this history, when we asked her the detailed history of anything in the past of fever, illness, or anything she was suffering of, she said she has nothing of that sort. Looking at her medical records, it was all normal. Neither she was a hypertensive, neither a diabetic. Looking at the ocular examination, her visual acuity was 6 by 36 in the right eye, and the pupils were normal size and reacting to the light, and she had a nuclear sclerosis of grade 2 in that eye. In the left eye, she had a cataract surgery with a PCIOL in position and has a 6/9 vision in that eye. This is the 9-gaze photograph, and you can see that there was a complete ptosis in this eye, and she had a adduction restriction in that eye, and it was clearly pointing out to a case of a isolated third nerve palsy without the pupil being affected. So when we see that the pupil is not affected, we are little bit relaxed enough and thought that it can be maybe something to do with a intracranial tumor which may be affected, as she was an elderly lady. Fundus was actually normal, but when we examined her, this is what we saw. There was a swelling in the medial end of the right clavicle near the sternocleidomastoid joint, which was 5 into 4 centimeter, bony, hard and tender. Chest X-ray, we are advised for a chest X-ray, and we could see a expansile osteolytic lesion in the medial 1/3 of the right clavicle, along with a pathological fracture. So when we also asked her, did you have any back pain? Did you have any pain in the she said yes, it was there sometimes, as they say always. So we took the help, when we ordered for a routine checkup of blood investigations. When it came out to be normal, we took the help of our physicians, and they actually said what we got was the ESR, which was high, and the serum viscosity was high. So they asked for the other things, keeping something in mind, and that is what came out to be immunoglobulin A and G with the M spike, and the urine analysis showed a Ben-Jones protein. What we also did was the FNSC from that mass, and then it collaborated to that. There was a plasma cell with eccentric nuclei, which was suggestive of low-grade multiple myeloma. Since the MRI brain and orbit, which she was already carrying because she had gone to multiple to one of the ophthalmologists before she came, which was normal, she was advised for this T99 phase 3 bone scan, and that also showed a low-grade malignant process involving the medial part of the right clavicle. So she was started on chemotherapy with CD regimen, cyclophosphamide 400 mg for weekly, thalidomide 50 mg daily for 2 weeks, followed by 100 mg daily for the next course of 4 weeks, and dexamethasone 200 mg daily once a week. And after 4 weeks, when we saw, there was a resolution of the third nerve palsy. So what we say in multiple myeloma is a neoplastic proliferation of the malignant plasma cells that secrete monoclonal proteins. The what we have to say, they usually present with the bone pain, and they can have a fatigue, they can have a weight loss, and they can have a anemia also. But our patient did not give any of this. So why did she have an isolated cranial nerve as the first symptom which was presenting? It can be because of the hematological process, which was a hyperviscosity in our case, which we saw. It can be because of microvascular effect, or it can be because of a direct compressive effect of the basal cell or cavernous sinus or the orbital apex by the intracranial plasmacytoma. So literature review said that the first case was reported by Sundaran et al., and then Kashyap et al. Also saw 2 patients in which they saw that during the course of chemotherapy, one of them developed abducens palsy, and the other was presenting with third nerve, which later had a basal cell plasmacytoma. So you can see third nerve palsy even after resection of this tumor masses, and so they can have a varied things when they will be presenting. So managing a third nerve palsy, it requires addressing the etiology. So just not looking and saying that it's isolated and can be hypertension or a diabetes. So keeping the mind of vascular risk factors, neuroimaging and lab tests are crucial in evaluating any isolated cranial nerve palsy. I come to the second case. This was a 56-year-old male who presented with left-sided headache for 3 months, pain and drooping of the left eye for 10 days with a normal medical history, and the anterior segment was normal, but the pupil was mid-dilated and was sluggish reacting to the light. So this is the picture, fundus picture which we are seeing, where you can see the left fundus is having a disc pallor in these cases, but the lower rim was literally normal. This is the OCT picture of the patient, which is showing thinning of the RNFL of the superior nasal and temporal quadrants of the left optic disc. So this is what was showing the field defects, and he was diagnosed as a non-arthritic AION, but a diagnosis of a painful like a pupil affecting the third nerve which was made, and he was asked for a CT angio in this case to rule out any posterior communicating aneurysm, but MRI brain and orbit showed that there was an enhancement in this area of the superior orbital fissure and optic nerve canal and the orbital apex. So since we had also this patient had other symptoms slowly developing, and we had to take the help of our respiratory physicians into the play, and she was asked for a PET scan because we could not go deep and take any any tissue from that area. So it was performed after 6 weeks of the initial presentation, and there was a hilar lymphadenopathy, and then he has to undergo a endobrachial guided needle aspiration, which showed a non-granulomatous lesion, which was suspected to be of sarcoidosis. All the blood investigations were normal in that case, so a diagnosis with a neurologist was a sarcoidosis and started on treatment. I'm not going about the treatment part. What I wanted to emphasize here is painful pupil involving third nerve palsy is commonly due to posterior communicating artery aneurysms, and however other compressive lesions must be ruled out when CT angiogram is normal. Always think of a compressive lesion involving the superior orbital fissure in any patient presenting with both third nerve palsy and optic neuropathy. And there are modern imaging you can take help of, and diagnosing a neurosarcosis is not always easy, but it can help us out. So this is my last case. This is a 30-year-old female who presented with fever, headache, sudden onset of drooping of the right lid for 5 days, and there was a restriction of adduction in these cases with exotropia, and there was a total third nerve palsy, but the pupil was normal and reacting. Her all blood investigations was normal, and slowly on the process she developed neck rigidity, and LP was done in these cases. Proteins and cells were raised, and other parameters was almost normal. She was asked for a neuroimaging, and this is what we are seeing in the neuroimaging. In this, we don't see anything caseating in this, but this is what was the lesion. So what I was trying to say, there was a basal exudates in that, and she was diagnosed as a case of a TB meningitis and started her treatment, ATT treatment, and slowly her third nerve palsy resolved. So TB meningitis presenting as a febrile illness with features of meningeal irritation and a previously unreported finding of complete ocular nerve palsy due to this basal exudates is quite rare, because most of the cases are usually presenting as tuberculoma in the brainstem. So these are certain things also we have to keep in mind when we see different manifestations of a isolated third nerve palsy. So my take-home message is cranial nerve palsy can be the first manifestation of systemic illness. Painful people involving third nerve is an emergency, as aneurysm is the most common cause, but we have to also think of neurosarcoidosis, which can be kept, and certain vasculitis, other things should be kept in mind. And TB meningitis should be suspected in all patients having cranial nerve palsies in the setting of meningitis-like illness, and neuroimaging is a must in painful, progressive, sudden onset palsies, and also in young patients, to help for saving the life as well as sight. Thank you.
Now we end up our session, and
Any questions you would like to take? If any questions. Okay, if not, then we are concluding our sessions.
on करके बोलो.